Thank you for joining us for this Court Connects about NPSA Day. Today we have with us Dr. Loice Swisher, Dr. Angela Chen, Dr. Lance Clemsen, and Dr. Michael Takacs. And they'll be talking today about physician suicide awareness and prevention. So Dr. Swisher.
Hi, everybody. Give me a minute here. I'm going to share some slides. So this past Saturday was the 5th National Physician Suicide Awareness Day. And I wanted to express my thanks to CORD because it really was out of CORD that this all started. I thought it would be good to, for people who might not know, give a little history. This all started within CORD on January 11th, 2016, when Dr. Christopher Doty wrote a letter out to the CORD listserv with the subject line, "It's with a heavy heart I write this." And personally, I knew before I even opened the email that this was probably related to a suicide. And it was. One of his second-year residents died by suicide. And in that letter, he called on us to shine a light and speak its name and create a legacy for this resident. And I felt compelled, given that I had traveled down that suicide journey to crisis, that we really needed to talk about it. It happened to be that same 16, there were 3 people that came together to form the Resilience Committee. It was the first time we had a Resilience Committee, and that was Dr. Raman Tabatabai on the right, Arlene Chung in the middle, and Dan Lakoff on the right. When we went to Nashville for Academic Assembly in 2016, myself, Dr. Doty, these 3 individuals all met for that very first Resilience Committee. And I think there were 50 people there. And over the next 2 years, talking together, we came up with the idea that to really be able to talk about this, we needed to have a day in the curriculum, a time set aside for us to talk about our experiences, to remember other physicians who have experienced this journey, and to really have the time for education. So it was in 2007, the beginning of 2018, 5 of us were on a phone call and decided to set a day and make a logo and choose the colors. The teal and purple are the suicide prevention colors. September 17th is right in the middle of Suicide Prevention Month overall. And the reason why Shine a Light and Speak Its Name comes from that initial letter. Since that time, we've become more open talking about this. And we'll have my 3 other co-presenters here, Dr. Angela Chen and Lance Clemsen and Mike Takacs from Iowa, talk about some of their experiences. In San Diego, there was a panel discussion regarding the Iowa experience and their experience with suicide and sudden death. Let me take myself off share so Mike and Lance can talk some about their experiences and lessons learned.
Thanks, Lois. So unfortunately, I was a program director during 3 resident deaths at the University of Iowa. The first one was 3 or 4 years ago, where a resident from a different service died by suicide very, very early in her training. She did not have a lot of, hadn't really bonded with residents in emergency medicine. I assume she had some bonds in her own residency class. Her parents didn't want much shared from this, and she had a chronic medical problem. And our residents didn't seem very affected by it, and we didn't really talk about it too much. And then about 2 years later, another resident died in our hospital by suicide. This resident was again from a different specialty, and he had very close relationships with some of our own emergency medicine residents. And this was really, really difficult. And what really shocked me looking back is how profoundly this affected our residents, whether they knew him very well or if not, just because they were friends with people in our own residency that knew him very well. And with that, we ended up excusing people from work. We ended up having a grief session, and it was right near the end of residency. It was the last week of June. It made it a very awkward time to provide long-term resources for residents, but we did our best to provide counseling time off for our residents to get through this crisis. Lance Clemsen was a big part of that. He's our emergency medicine psych social worker. Lance, do you want to recall a little bit about that time before we talk about the last one?
Sure. And Mike, I don't know that I have a whole lot else to share other than I too was kind of struck by the different responses. And I think it had to do a lot with our residents who didn't have a direct relationship with him, certainly knew of him, and also were keenly aware of how valued he was. And I think the other part was just how much of a shock, a surprise that particular death was. Literally the night before his death, the faculty were all gathering at an end of the year event to kind of congratulate the graduating residents. And I heard over and over and over again from that department, no one had a clue. I was involved with that department during the various steps, communicating with the parents, talking with that department's residents, and also providing some additional resources to the emergency medicine department. It was really a shocker, as they all are. Many people were thinking, why did I not pick up on this? I just saw him last night.
Yeah, since the lessons learned there was how difficult it is to perceive mental health in a resident. And from my understanding, he was a very successful resident. There were no red flags, and he was just really admired by his colleagues. And the other lesson learned was how profoundly our residency was affected by his death, whether they were a close friendship or not. And that really opened my eyes on the importance to keep our programs going that we had, and to just keep engaging in the conversation on physician suicide and awareness.
And Mike, let me just interrupt one moment, because I had a couple more thoughts that just came back to me. One was his father is also a physician. He was very open to turning this into a learning experience. Several meetings after the initial one, we did learn that this particular resident did have some mental health challenges. It was news to everybody in that particular department.
And then the third death was not considered a suicide. This resident, Rhodey, was an emergency medicine resident, and that was his nickname, Rhodey. He was very open on his mental health and that he had depression, and he had people checking in on him all the time. And he was extremely bright in his third-year residency, doing extremely well. But he was also at the same time telling us that he suffers from depression, and but he's okay. But that was enough for us to constantly check in on him. And he developed amazing friendships throughout residency. He was a history buff, and he used to talk on the phone with a faculty member every other night about history. He would check in on other residents to see how they were doing. And by that, he was sort of like getting his own self check-in. Also, he would talk to me, two other APDs, Vice Chair Education, and it was just a constant, awareness of how he was doing. And then things started spiraling down a little bit, that he started getting sick, but he came up with an excuse on that it wasn't serious, and he made it sound very believable, and in respect of his PHI and his own mental health, where we didn't want to cross barriers. We were still checking in on him, and he said he was doing fine. And things took a turn for the worse, and he ended up dying from complications of liver failure. It just went fulminant liver failure in the last 24 hours, and it was an incredible shock to our residency program, because we thought we were doing so much for him. So immediately, he ended up dying on a Saturday morning, sometime around 5 in the morning or 6 in the morning is when I found out. And we did not have like a phone tree in place for something like this. A lot of residents had the weekend off. They're gone, enjoying their weekend somewhere. It was despite HIPAA and PHI, word can travel. I mean, it's hard not to. And so I called one of our chief residents up, explained to her what happened, and then our department chair sent an email out explaining that he had died, and that we were offering a group meeting and counseling that same day, and to start to bring everybody together to help heal, because he was a very loved resident.
One of the things about that history too, Mike, and again, a lot of this is coming back, is there were several of us on the Friday before the Saturday he died who were helping to facilitate him getting care, and particularly a couple of the chief residents. The concern was that if they brought him to the University of Iowa, everybody would know him. And so the arrangements were made to go up the road, probably 20 miles or so. And then unfortunately, his health took a major change for the worse. He ended up being then transferred down to our hospital, and nurses who kind of control the bed management, the bed board, of course, recognized his name. And then I think about that time is when words started kind of seeping out, what's going on with Rhodey? Did you see this? Those kinds of things, despite all of the efforts to respect his confidentiality.
Yes, that made it very nerve-wracking as a program director, because a couple of residents had contacted me, and they heard through the grapevine, and they were, of course, very upset that this happened in protection of his PHI. I wouldn't, any PHI break is serious. It's not like there was email sent. It was a couple words of mouth, I believe, and then I think people realized that they shouldn't be talking about this anymore, and then it's pretty much stopped. The one thing that was helpful was talking to his mom right early on. I called her to let her know he's in the hospital, which she already did know, and I called her to find out how much medical information I could release, because people know him and care about him so much. And she was very open that he would want people to know what's going on, that you could feel free to share with others, and so that made things a lot somewhat easier on our end to overcome that issue on his immediate serious illness. But of course, getting back to mental health, what this talk is all about, it made me wonder, what did we do wrong? What could we have done better? And, you know, looking back, I think there were two things. Is he would come up with, I said his mental or his physical health started failing the last week of his life. He would come up with really, really believable stories that he was under medical care, and also I think his psychiatric care. And I don't think he was seeing anybody for any of this. And down at the end, and I think he may have just given up on life. I don't know. It's an educated guess, but he was, you know, it was very believable. And but he died of liver failure, which normally doesn't happen in this day and age, especially in someone so young.
Which then led to the whole dynamic in the department of, you know, we should have known. Why didn't we? We had these symptoms in front of us. And I have to tell you, he was really convincing when you would approach him about what was occurring. Very believable.
Yes, yes. So after he died, we had a session with our COPE team, and people was very highly attended, and people were asked questions, express their emotions. It helped start the healing. There were another thing that was really fabulous was a number of get-togethers by residents. And by faculty sponsored and resident sponsored. And I'd say our one chief resident, Karen Sandari, did an amazing job in getting everybody together for basically a department-wide function at her house. And so that was really helpful to come together as a group. Our department was extremely supportive. All the residents got off of work, no matter what service they're on. You know, we have 9 residents per class, and so faculty signed up to cover the ER. Some off-service residents just showed up to work in the emergency room that weekend, and things were covered. And then residents came back to work about day 3 or 4 afterwards. And then his funeral was the Friday following, and the department gave everybody off of work to attend the funeral. And so, having a very supportive department chair, department faculty, other departments in the hospital was really helpful in getting through this.
Yeah. Loice, you have your hand up. Was that by accident, or do you have a question?
I didn't see that I had my hand up. I'm
Okay,
sorry.
all right. Would you like me to talk about, I guess some lessons learned, so to speak, kind of looking back on this? Okay, maybe this is a nice segue.
Yeah.
I mean, first and foremost, nobody can prepare you for something like this. It's kind of like when you least expect it. It was devastating. And it is not the same as a patient who comes in who has gone through some kind of a horrific tragedy. This is family. And you have to approach it with that kind of mindset. And what Mike described is our department really, really got that and really stepped up. And I would say the family came together initially. It's always easy to kind of be the Monday morning quarterback and look back and say, well, I should have done this, I should have done that. I don't want to come across that way. But I do want to emphasize some things that I think are essential that should be occurring regardless if you have someone as ill as Rhodey or the other circumstance. And sometimes they're the basics in my mind that easily get kind of forgotten in the work that we do. The first one is that leadership, our clinical leadership, our department leadership really has to normalize the difficult, overwhelming work that we do. There's very few places in a hospital setting like this where we encounter day after day after day the kinds of presentations that we have. That's not news to anybody. When we have young learners, people who are fresh out of their medical training, some of us who've been in the department for a long time tend to forget what the impact is like of that. And we kind of take it for granted. And working with, in terms of modeling, that we struggle with this is something that I can't emphasize enough. It's simple to say, it's hard to do. And in terms of how that affects you personally in those particular encounters, and probably most importantly is reaching out, leading by example, that I reach out to other people and putting that into words, particularly for the young learners, the people that you're mentoring. Second one is true connections with people. Never underestimate the value of a healthy relationship. And by that, it isn't just me walking by and saying, hey, how are you? And I keep walking and really don't wait, for your answer. But I really do stop and I'm present with the person and hear what they have to say, especially for my colleagues who I have some concerns about. I make the extra time to say, no, really, what you went through yesterday was awful. I could tell by your facial expressions that that was grueling. I just want, to follow up with you and truly see how you're doing. And you got to be present for that. You can't say that with 4 other things on your mind. You really have to set it aside and make that person the priority. And then follow up again and follow up again. There's something very, very powerful about sharing our own experiences when we've struggled, which all of us have, in terms of normalizing and having a safe person to disclose it to. The follow-up can't be punitive. It can't be you're in trouble. You blew it on that procedure. It has to truly be about you and how are you, sincerely. The next category is debriefing. And, we give that lip service. We don't do it very often. There are some, that we do that. But debriefing just has to be part of our protocols. We have algorithms for lots of things, but we don't have that when there is something that is especially challenging. And it's always the eyes of the beholder. What affects me may not affect you, so on and so forth. But in this field, given the kinds of things that we encounter multiple times a day, debriefing has to be part of before we go on to the next step. We have to do that, not just give it lip service. It's what we do, basically. And then the next one is that everybody's got to have their go-to person. Somebody who maybe is a mentor, maybe is a colleague, maybe is at an equivalent level, but you got to have somebody that you can go to who is safe, who is trustworthy, who's going to be able to be very candid with you and help you kind of facilitate what needs to be done next. It's like knowing that person has your back, that is going to take care of you. Because again, the power of debriefing, whether it's in a group or with somebody else, the literature is consistent, basically, over and over again about the impact upon that in terms of preventing down road complications. And then my last point is we need to have a pathway, a process. And by that, we need like a roadmap. When you detect a colleague is struggling, here's what you do. When you're reaching out, here's where you go. Here's the people that you talk to. As opposed to trying to think it through all in the heat of the moment, right after the stress, weeks after the stressor, you want it to be simple. in terms of making those connections, again, in a non-punitive way. It's overwhelming. It's hard to figure out, should I not do something about it? Make it easy for your colleagues by saying, this is what worked for me, here's the pathway, I'll even go with you if you need that. Now, again, these things are easy to say. They're not easy to do. Think about how many things we drill for, how many things we practice for. How many of you practice that you're going to have a trauma with one of your colleagues? Nobody. Nobody does that. Now ask, why not? It's going to happen. And whether it's something as horrible as what we experienced here with those 3 deaths, something bad is going to happen. I mean, that's just the nature of human beings. And to have a structure in place that really pulls together the community quickly, to be mutually supportive, to minimize the gossip, the rumor mill, all of those kinds of things where we provide factual information on a timely basis to work that through, have it in place. Hopefully that will become as just commonly discussed as a fire drill. In Iowa, we have tornado drills, all of those kinds of things. In other words, a drill to take care of each other.
Thank you very much, Lance, for that. I think there are a lot of important points in this. And I know you had asked me whether CORD specifically had any resources on sudden resident death. And in the chat, I'm going to put our survival packet that came together on talking about different experiences, people from CORD that have had issues with sudden resident death, illnesses with their residents. And in that packet, there are phone numbers of people that you can call who have been down this road. One of the things that we didn't highlight in the second half coming up, but that Mike talked about, is that preparing for the communication. And Friday seems to be a time that some of these things happen, and getting into the communication with family and residents. There are ways you can sort of prepare for that communication tree, because when you need it, it's really tough to do if you haven't thought about it before. So I thought that those were really, really good points. In our second half of this presentation, thinking about these episodes, the one with Chris Doty in 2016, where he was unaware, and the Iowa experience, where despite the past 5 years, we still weren't aware. And it hurts my heart to think, what are we going to do? Lance gave us several ideas, but in the 5 years, I've gathered some different thoughts. And we'll start with Mike has one on EAPs. Angela had done some research through the mini fellowship, and we were paired. I was the mentor, she was the mentee, and at the end of her mini fellowship, had a platform presentation in Seattle on her research on safety planning. And I'd like to end a little bit on the licensure issue, which still comes back. So let me get those slides back up. Mike, I think you wanted to talk about your experience with EAP.
Yes, this was a brainchild of one of our chief residents about 3 or 4 years ago, Tim Watalka. And he came up with this program where he reached out to EAP to see if we could have time slots that were open only to emergency medicine residents. And they could voluntarily sign up for these time slots. And then by attending, they would get 1 hour of conference credit. And then if they wrote a self-reflection and kept it for themselves, and just by honor system, they would get another hour of conference credit. That is asynchronous credit. And so residents that did this, they took advantage because they liked the conference credit. Some had mental health issues that were very helpful to be addressed by EAP, which they wouldn't have sought out otherwise. And then there's really surprising thing to me, there were numbers of residents, and I didn't ask for them to come up to me. They just would come up to me and they said, I never thought I would ever talk to a counselor or benefit from talking to a counselor. And wow, what a difference, this has made in my life by talking to somebody. And I never realized like how much stress I'm under and how difficult my job is. And so this program was just a huge success, ended up being a podium presentation at CORD, and a big winner for our residents. I just actually dovetailed this into National Physician Suicide Awareness Day and had the residents, I gave them like 5 or different links, including the CORD link, ASAP link, the NPSA links. And I told them that if they, again, spend 30 minutes reviewing these links and then just 30 minutes reflecting on what they read on Saturday, and they could, by honor system, email our conference coordinator to get 1 hour of asynchronous credit. And I told them I felt this would be so helpful for them that I'm willing to award this credit. And if my residents could attest that I'm very stingy on conference credit and very curmudgeonly, and they know that. So by allowing this leeway, just kind of shows the from me to them the importance of them taking this serious.
I really like that idea of making the importance with conference credit. I wanted to mention 2 nights ago, the mini fellowship had Greg Gunler talk about UC Riverside and people that were concerned about having to say that they went to a counselor. He's incorporated this as part of their curriculum. So if anybody asked about using EAP, he said that he thought having it as part of the curriculum and understanding counseling and what patients go through, that all they would have to say is that this is part of the curriculum to understand that aspect of care. So I think that this is an exciting thing. Let me change the slide here for Angela to talk about safety planning. And I know you have a couple slides, just let me know when you want me to change them.
Okay, thank you so much, Lois. So the idea of safety planning kind of came about when there were kind of a chain of residents dying by suicide in New York City. And we really saw a plethora of residents who all followed a similar pattern, all around a similar time. Like Lois mentioned, it would happen like at the end of the week. And this common theme kept prevailing, which was that nobody saw it coming. Everybody kind of cited that these residents were really, really capable. They seemed to be very social, and no one really seemed to identify that they were struggling. And so this really drove us to think a little bit about, who are the people who go on to die by suicide? And if we have such a hard time identifying who those residents are, what tools can we use and what tools are in place so that we can give them resources at hand? And we just have to assume that these resources have to go to everybody because we're so bad at predicting who are the residents who will struggle in their training. This is Joyner's interpersonal theory of suicide, and it gives us a little bit of a model to think about, what drives people to have a successful suicide attempt. There's a couple of things that really have to be in place. The first is this idea that the person feels like they're alone. They have no one to turn to. The second is that they are a burden to those around them. And this together creates the desire for suicide. And then this third component is sometimes actually the most difficult to get across over for people to actually have a successful suicide attempt. And that's the capability for suicide, that I'm not afraid to die. Human beings have evolved so that we have this innate desire for survival. And to overcome that requires a lot of kind of factors to be in place, most notably kind of exposure to death and dying that desensitizes us to the fear of death. But what I learned about this model, what I realized was In some ways, for our young learners coming right out of medical school and into residency, these three components really, really prevail, especially early on in training. And using this kind of model, we realized that every resident, when entering training, might develop kind of an increased risk for suicidality. So looking at that, we looked at a little bit of kind of the tools that already exist in psychiatry. And what we did was, Lois, if you don't mind going to the next slide, we created a crisis management plan, which is an escalated step-by-step approach, so that when residents are not in crisis, they list out the resources that they have, so that as they find themselves escalating into some sort of emotional, mental health, or suicide crisis, they're able to go through these steps in an effort to de-escalate themselves. Just going through this very quickly, the first is to identify warning signs for themselves, clinical scenarios that might put them at an increased kind of risk for any kind of crisis. The second is internal coping strategies that they can use. For example, a quiet place to go if they're on shift, even just taking 5 minutes during a particularly stressful shift to step away, breathe, and just take themselves out of the environment. People and social settings to remove distraction, so that they can, go for a run with someone, people to ask for help. And then finally, professionals and agencies. So we're lucky to have a very, very robust mental health service specifically for the residents where I am. So I actually put that number on there. We put the numbers of our residency leadership, our PD, our APDs, just because when sometimes I think someone is in the throes of crisis, the hurdles to actually locate resources and to locate help can feel so overwhelming. And then finally, the sixth step is just to make the environment safe. Because also all the research has shown that if you can kind of create a deterrent and have that person in that moment of suicidal thinking, they often are able to move beyond that desire to die by suicide. So we actually hand this out. We do a session with the residents, with the interns, at every intern orientation. We do a full hour to it. And I think partly we also have chiefs, we have members of residency leadership share times in their training and beyond that they have struggled. It's a very frank, honest discussion, and I think it sets the tone very, very early on for the interns coming in that mental health is something to be very, very cognizant of throughout their training. It normalizes the conversation. Lance talked a lot about how I think sharing your own stories can be incredibly powerful. And I know that I have had residents come to me and say, I really am struggling. And part of the reason I reached out to you was because I remember what the story that you told about yourself during intern orientation. I think it provides a lot of context for why this crisis management plan might be needed in their residency. And it also really creates a framework for how they might be able to reach out to resources if they find themselves struggling. One of the things that I actually tell them to do is that steps 3 and 4, people to ask for help. I actually tell them if they're comfortable to let the people who they write down know, I've listed you as someone who I might turn to if I'm struggling, because I think it's important also that people who are not in medicine realize the tremendous toll that what we see on a daily basis, especially in the emergency department, might have on our mental health. And so I've been collecting data on this. Lois, if you don't mind going on to the next slide. I've been collecting data on this for about 3 years now. And so we ask a couple of questions initially. What we ask is their self-perception of being at risk of becoming depressed or suicidal in residency. And so over the last 3 years, you can find that actually more than half of people think of interns coming in think that they might have some risk of becoming depressed or suicidal. And then I usually touch base at 3 months into training, so around September, October, and a third of people have actually used the personal crisis plan in the past 3 months. They used it to identify someone that they can reach out to. Some of them have used it to get in touch with our student training mental health, which is our mental health resource specifically for residents. And a lot of people use this plan and kind of even just to identify that maybe they're not doing as well as they thought they would be, that perhaps they need to take some time to reflect and really take care of their own mental health. So far it seems to be working, or at least our residents, the feedback that we've gotten is that it's been valuable. It's also been kind of used at a couple of different programs now and also outside the specialty. And it seems to be garnering a fairly similar response in terms of its utility.
Thank you. I think safety planning is a very important thing, not only for physicians, but for patients as well. It's good for emergency medicine docs to know this. So my part on this is I want to talk about licensing and credentialing. Back in February of 2017, I got this email from somebody in program leadership asking for my advice on a resident who gave a talk on physician suicide. And as he was talking about this, he said his friend had died by suicide. He said, you shouldn't tell your program director or anyone else in residency leadership because they will have to disclose this to licensing boards and future employers. And that person in program leadership was very concerned. We talked on the phone and said that they looked sort of to each other in the conference. And was this something that, how would they address it? Residents really truly believed that they were at risk if they talked about it, and program directors wanted to know. So the question at the end was, are there any guidelines out there? And certainly in 2017, there really was not.
Loice, can I add a comment on this?
Sure.
So we've never had a resident ever bring this up in my tenure as program director in my 9th year until this last 6 months, and this was brought up multiple times, and I've never X'd any box in a negative way, but somehow residents, in our program, got a concern somewhere. I don't know if it was, through EMRA or through some leadership boards, or but they definitely sense there's a serious concern about this, and so I'm glad you're bringing this topic up.
Well, thank you. It definitely is a current out there that residents think of. And this morning was my first time giving a grand rounds on this issue. One of the medical students who is applying to emergency medicine said that she just finished her application, and on it asks about mental health issues. So that may actually start even earlier with this undercurrent of being concerned. If I check that box, yes, will I get a residency? And just continues on. So to answer the question now, I have 3 thoughts. One is to have a transparency of process and consequences. Secondly, to highlight there are changes going on that they may not be aware of. And the third is to, at the very least, know your state. And people in program leadership know what their license says. And if you can address those 3 issues, I think that that's a start. So on the transparency of process and consequences, when you check that box, yes, or when you go to your program director, what's going to happen? I know that there's a lot of words on this page. I'll be able to send this out to anybody who asks. But I've seen one program director, this was sent to me by a resident, on what their explaining if they came with a concern about themselves or another resident, what would happen? And that made this resident feel much more safe because they knew at least a little bit about what would happen. So I think this type of letter where you say, if you come and discuss your own issues, if you come with a concern about a colleague, what is going to happen? And that very last paragraph of our specialty is full of mini PTSDs that our specialty is. And some of this is just being an emergency physician and to reach out to each other. I think that that's very important. So that's one thing you can do. The second thing is, since 2018, there's been significant changes with the state licensure wording. And in this Newsy video, there is the QR code, but if you do Newsy unspoken doctor depression, you'll come up with this video. It's only 18 minutes, but it goes over what was their recommendations for changing language. And here were the top 4. One is you should evaluate whether you should even be asking about mental health. The second is really focus on impairment, not illness, whether a physician is impaired, to limit the history at least to 2 years or less, and also to allow for safe haven non-reporting, that if you are in therapy, that you do not have to report. But I caution you that it takes time for such licensure and regulation. 2021, I think May, this article came out in JAMA that was looked at states prior to July of 2020. It's not enough time. It says one state was following all those 4 recommendations and 5 followed none. That's not all the story. It's not exactly true. If you really looked at the data, 39 states by that time, a year and a half later, limited mental health questions to just impairment and 41 to current condition. 25 states had safe haven reporting and 8 incorporated supportive language. It takes time for this to change, but it is changing. And this map is currently on the AMWA Humans Before Heroes I've helped work with, to look at each state, what that language is. I want to draw attention to a red state, Florida, which I'm now living in, and a blue state, Mississippi, to talk about the language. In October 2020, after that JAMA article came out, Florida, which had been in the process of changing the language, went from 6 questions to 2 questions. It did divide out physical and mental health from substance abuse. And with physical and mental health limited to impairment in the last 2 years, and more specifically and helpful, it clarifies in the application that they do not want to trigger a positive response, somebody checking yes, for assistance with stress, mild anxiety, situational depression, family or marital issues. And if these will not affect the outcome of your Florida healthcare practitioner application. They don't want to know about that. And I think that clarification of what is and is not included is important. The blue state, Mississippi, it's also North Carolina now as well, changed their licensure information to be an attestation where a physician is asked to take care of their mental and physical health. If they don't, that could be a problem if it affects patient care. But there are no other questions. You're just attesting that you will take care of yourself. And I think that that's actually better than no questions at all. Oh, let me go. So let me give a minute hear, anybody have any questions from the audience? So, Mike, Tim in the chat said, asked about the EAP, and how were the EAP sessions allowed to be scheduled? Were they during the didactic time, or how did you figure that out?
Mike, you need to unmute, Mike.
Initially we had 4 or 5 hours of the week set aside for us that we could schedule in advance. They were not part of conference time. They were separate from conference time. And so we just worked with EAP in advance. Now residents just schedule on their own because this has sort of opened the door for other residencies to do this at Iowa, and much more, it's being utilized more. And I think EAP access is a lot easier than it was when we originally set this program up.
Tim, did you want to ask any further questions to that follow-up?
Well, no, I appreciate that. I mean, we've had residents approach us who have been seeing their therapist successfully on EM rotations, but can't fit it into non-EM rotations. Like when they're in the ICU, they can't leave for an hour in the middle of the day, even to do it via telehealth. And so I don't know if CORD has a statement, or if anyone, like we're debating whether or not, we've told them they can be excused from conference, but then we're debating how, in an effort to support this, if they can get conference credit for that time or not. I just don't know if anyone's kind of figured that out.
And we give asynchronous credit because it's not entirely fits the rule for conference credit. And then as far as another statement, the ACGME has a statement in their common program requirements that residents need time to make appointments. And it really doesn't specify you can't have time when you're not on an ICU. Unfortunately, I think we have the same problem you guys do, and that it's very hard to get residents out of an ICU to attend a meeting or attend conference, or because it's such a demanding rotation.
I don't know if anybody else has any comments on their EAP issues. I see Robin talked about the opt-out program that they created. I guess every resident gets a call, and they have to take the call from EAP.
Yes, we had a little bit of a barrier compared to the Greg Goldner program, because their program was a subset within the College of Medicine right there. And we're part of a consortium. So our College of Medicine is 2 hours away, and there's not one clinic that we could negotiate with to make appointments. So the EAP program is a national program that uses telephone to either refer locally if they request it, or have telemedicine. And because of those, and because the EAP was worried about they were worried about not talking to the resident to do their 3 screening questions to make sure they weren't in crisis at that moment. They wanted to talk to the residents. So I made it a conference requirement and a mandatory, and made the calls happen during conference time and scheduled them out over like 3 weeks. And so they had to take the call, and all they had to do is say, no, I don't want to talk to you again about this, or yeah, let's set something up. And so that was the closest I could come to giving them all the power, but making it the easiest, kind of delivering it to them. And we were very lucky, Dr. Fallon, because we're on the East Coast. So there were people who, like therapists who were living, I guess, on the West Coast, who would have later hours. And so with the telemedicine, there was a lot of flexibility for the residents, as far as I know. And then what was also very helpful in moving that forward was that I, as a program director, have no idea if any of my residents, except when they tell me, are utilizing the program, and making sure the residents understand that. Like, no one at UCF, which is my sponsoring institution, no one in our residency, no one at the hospital no one knows if they are utilizing the EAP or not, and will never be told, and no report will ever be given to us. So that, I think, helped them know that we're not like, we're never going to find out. So it's completely, absolutely up to them.
I do think that telemedicine has made a difference. We didn't mention much about COVID, but that ability to use telehealth has also really impacted the mental health community, I think, as well. Are there any other questions or thoughts that anybody wanted to bring up?
Just we talked about this earlier, but didn't come up on this meeting, but you mentioned COVID. You know, we feel, you know, our Angela and Lois and probably Lance too, that this group of residents right now are 3s, 2s, and 1s. They've all experienced COVID as a medical student, and their medical student training was curtailed, less hours, less clinical time with patients. And so the step from medical school to residency is tremendous, way more than it's ever been. And so that additional stress means that the time we're under right now might be the most stressful time ever for a residency class. So I think we just need to be aware of that.
Thank you very much to everybody for being here, for CORD for giving us the opportunity to talk about this 5th National Physician Suicide Awareness Day and bring this topic again to light, and to my co-presenters, Angela, Mike, and Lance. I really appreciate you having the afternoon here. And as we leave, I just wanted to share that SAEM is going to be taking the lead in October on Stop the Stigma EM and breaking down the barriers to mental health care and emergency medicine. I think each of the national organizations will be taking some time to highlight that, and it may be another time in residency programs to talk about stopping the stigma. Thank you very much.